Evening, guys. Let's get Jazz on. We're going to have a chat today about digital versus analog. You can pick your side. Hopefully he's looking good. He's got the protrusive background at the green screen. Hey, Gary. First man in. Good job. See if we can get him.
This is a cool way to do it. Hello, hello.
I'm liking the green screen. Are we going to get some special effects halfway through?
I don't know, actually. Let's figure it out. While you welcome everyone and host everyone, let me see if I just made myself fat. That's not good. Oh my God, this is not cool. See, I always struggle to find the green screen one, but I'll find it. Give me a moment. Oh shit, we don't want that.
So whilst Jazz just goes through every single possible thing, so yeah, we're just going to go through and have a little debate really about analog versus digital. I don't think we're overly going to pick sides. But yeah, I think we're just going to go through, and it'd be cool if everyone just sort of pops in comments or the Q&A bit about their thoughts. And if you have any questions for us through, we'll try and just, answer them as we go along. So yeah, man, how you doing? How's your day?
Today was amazing. Today was the first time my son went to nursery not crying.
Oh, I know I've been keeping track of it. It's been a few weeks, isn't it?
It's been great in that sense, man. How was your day?
I can't even remember. It was a bit blur, really.
How many impressions did you take? I imagine when you go home, that's like Rupert's measure of life. Like how many impressions I took today.
How many impressions today? I did a scan today for an onlay. Mixing it up. And that was it. One scan. That was it. I did
zero impressions.
Three yesterday. So that makes up for it. Balances out, Two on average. That would do.
Have you got this empty void inside of you? For today?
Yeah, it's all right. It's all right. I think tomorrow's like full checkup, so that's the real day. That's for tomorrow. That's gonna be the big thing. Oh, Mike.
Oh, good old Mike.
Good old Mike. Mike's gonna be Mike. I've already got to Mike and I bribed him. He's on my corner with Team Analog, definitely. So I was telling him about the hybrid case that I'm doing. He's quite interested to hear about that. So we'll have a little chat about that. But yeah, I mean, if anyone who doesn't follow you, and I don't know why they're not, because they should be, and they should be subscribing to your awesome podcast, just give everyone a quick little intro about yourself and take it from there.
Hi guys, I'm Jaz Gulati. I'm a general dentist. I work very close to Rupert, actually. I work in a place called Tilehurst in Reading, and that's how when we started to connect on Instagram, I found out that actually he works nearby, so that was pretty cool. And then I found out that his practice, they have a module. Right. So if you don't know what a module is, it's like in Pixar where you got like the motion tracking and it connects to your mandible and you can track motion movement. So it'll be interesting to hear if your principal has let you had a go on that module or not. That'd be pretty coul to know. But essentially, yeah, I work in Richmond as well, and I'm passionate about dentistry. I'm passionate about occlusal appliances, power function management, and trying to we're all on this learning path together, and I just try and share it a bit more on my podcast, and that's me basically.
Yeah, definitely. And I think and not just plug-in because you're plug-in, but yeah, and not because plug-in because my episode's coming up soon, right? But
it is
definitely, the podcast is awesome. I sort of highlighted on my story today, that little jig, 100% like splint timber, that gave me the thinking to go and do that and confidence to go and tackle some of these things as well. So. Awesome stuff,
I actually had someone message me. Yes, ortho. So April is going to be straight pro. It's a terrible name, I know, but I had to follow something with Splintember, right? Something had a ring to it. But I had some people message me about that, Rupert. Actually, your little chairside jig you made today. You made it out of Bisacryl.
Yeah, Luxton. Yeah.
What did you use to stabilize to actually get the flat plane?
An impression handle.
There we are. The Don himself.
So I did 4 impressions yesterday. I used 4 impression handles yesterday. There you go. Yeah, no,
very good.
I sent my nurse running around trying to find a tongue depressor because the chap that I saw on Harley Street, he did it with like a big tongue depressor sort of thing. And they literally dug the whole place up and couldn't find one. So I just grabbed a tray, but it had a little hole in the bottom and the Luxemp flowed through and made a button. I had to cut it all off. It's a bit of a nightmare. That's the bit you don't see on Insta. Yeah, the behind the scenes.
But you managed to help someone, which is amazing. But that was really cool to see, actually. So cracking job, mate.
No, it was ace, and I need to do a little video now. I asked people about it, and it's had like 200 yeses, and no one said no. So I've got to go and do that now, haven't I? So my nurse is thrilled that I'm going to be demonstrating that on her at some point.
Brilliant.
Let's jump straight into it. I mean, you've mentioned module, so yeah, 100%. That's a cool digital thing to talk about with planning. And my hybrid case, we've used that, which is ace. What about for yourself in general? Are you doing a mix of both? Are you moving more and more towards digital?
I would say last year I was probably 90% digital, and now I'm probably 99% digital. Like before, the thing that was keeping me on analog was vertical preparations and trying to get subgingival enough. But I think now I've almost mastered it in my hands of getting a nice digital scan, very subgingival, and the crown's coming back fine. So I don't remember the last time I took an impression, man.
That hurts. I really do.
But I don't do any dentures, and if I do, they're coming your way. So I don't do many dentures at the moment. They're happy to come through, but I just don't get enough of the cases, which is weird because most of my patient base is like 60 plus. But anyone who's got a denture, they're just really happy with it. So no one ever needed a change.
Someone did a good job 5 years ago, so you're fine.
That's it.
Perfect. I mean, I'm definitely a lot more on the analog side. I've started scanning. I scan more or less all of my preps now. Although I had a really interesting one the other day where Itero, or the actual printing messed up. So it was a premolar prep, and it was a leaning 6, and I had to just adjust it slightly so that the path of insertion was fine, and it scanned fine, and the model and the actual 3D model was fine. But when it printed to cut the die out, it cut a huge chunk in the mesial of the 6, because that's how it's printed like that. Or sort of carved it out like that.
So you printed it at the practice?
No, at the lab. It came out of the lab. And I actually went to pick up some work for the hybrid case from the lab. And I'd sent it back to him. I was like, yeah, dude, this has happened. And it was one of those ones, you don't open it until the morning. And you go, oh, that's definitely. I was like, pretty sure I didn't butcher the neighbouring tooth. And I went in that evening to go to the lab to pick up this work for the next day, and he was like, yeah, I thought that was weird. I didn't think you'd normally prep it like that. And I was like, well, I'm kind of wish you'd called me. I thought you'd thought of actually going on that. So that was interesting. So that I actually ended up doing an old school impression for. Dentures, I'm 100% old school, apart from this one case, which we'll chat about in a bit. So I thought the first use, which is probably going to go digital, and sound where you're definitely doing it, study models, monitoring, tooth wear, things like that. Surely,
absolutely. So
chronological stuff.
Spot on, mate. Spot on. I mean, Itero is good. I mean, if anyone out there knows how to do it, best dentist in Southall, yes, Sonny. Best dentist in Canada, Sonny is. But no. Oh gosh, I lost my trail of thought now. What were we talking about? I just saw Sonny and got excited.
Study models, where?
Yeah. So the time lapse function on Itero. Now, if anyone, so I'll say, if anyone knows how to do it on 3Shape, please teach me, because I don't know how to compare a scan from 2017 to 2021 on 3Shape and tell me how much wear it's had. But on the Itero, where I use it occasionally, it's so easy, it's built in. So I don't know if 3Shape has it or not. I imagine it would, because it just seems bizarre to me. But that is phenomenal to measure tooth wear. And like the most common question I get is how much tooth wear is normal? The studies would indicate around about, for molars, 29 microns a year. So good luck measuring that one, guys. But over some years, you get an idea, right? So that's a phenomenal use. Have you guys got Itero?
Yeah, so we've got two. We had an old one, like a really old school one, like I think Itero 1, that we threw out in the skip the other day, which is really sad because that was probably like 40 grand when it came out or something. Yeah, we've got two. I think they're Elements, not the new ones, the really slick look there. But yeah, so we've got two, which I have to lug up and downstairs when I need it, which is annoying. But yeah, so we use Itero. I think Nick tried the Trios. He got sent one. I think it might still be in the practice somewhere. But he's mostly doing implant stuff. He just loves the Itero. It just works. And I think and we've got two guys that do tons of Invisalign. So obviously that's the way to do it. Are you doing it for new patients? Scans for new patients?
I'd say 80% of the time. If I know that they need more time with the chat, and that's going to be more meaningful for that patient, then great. But if it's part of their records, I know it's going to be a more complex plan, then yeah, I'll just take a scan, especially at Richmond with the iTero. I find that to scan on iTero is so much quicker than to scan on the 3Shape. So that is one factor as well. Like iTero is way quicker at scanning.
Greg's just saying, so could you measure intrusion if you deliberately induce it? And I assume you could really, because you've got a baseline scan, do a new scan. It's going to show you.
Absolutely. It will show you within a heat map. It will show you a heat map of how much is like a little bit yellow, orange, and all the parameters are there. So yes, you can definitely do that if you deliberately induce intrusion.
So this is what you'll like with the module, is it has a similar heat map through the movements, and it shows you what's in contact when things are moving. It's awesome. It like flashes up, and yeah, it's cool. Yeah, new patients, it's quite handy. I'm not doing it routinely. It was one of those things at the start of the new year. I told myself, I was like, right, every new patient, and I haven't got around to it. But yeah, certain cases, even if it's just like a quick scan that you just delete of just, because sometimes it might be better than a picture showing you a cracked cusp on a 6 or anything like that. I think it's valuable. And as well, I think patients quite impressed, by it if they've not had it. I mean, I had a guy that I knew, he's like a top hair transplant surgeon. You might be skulking, he's always on here somewhere. But he went for an Invisalign consultation, and he is top guy on Harley Street, international lecturer in his field or whatever. And he texted me straight away. He went, "Oh my God, they did this scan of my teeth, and it was so." And I was just like, if someone that high up in a medical field is that impressed by it, what does it do to the average? No, I'm not talking down anyone, but the average man on the street. It must be like, yeah. So I thought that's quite valuable for new patients, and is
very true.
And I think the thing where digital as well is probably pretty good is planning. So like this hybrid case that I'm doing.
Tell us about the hybrid case. Set the scene for those who haven't heard it. Just tell us about the hybrid.
So this is a case that I'm doing with my boss, Nick. It started off as being an all-on-4, all-on-6 implant case. Lots of broken teeth. But he came to us, I think, just after lockdown in June. In July, he had a massive heart attack. He's on dual platelet therapy. So his cardiologist is like, absolutely not. He can't come off these meds. He's not having all this surgery. And for that level of surgery, Nick wants to do sedation. And the anaesthetist is like, there's no way I'm coming in and anesthetizing this guy. So they'd already sort of started the process. They'd done scans. They'd done a module to work out centric relation and all his excursions. And they'd done a digital wax up for where they were going to do it. And they were going to move all the teeth back and all this kind of stuff. He then came in 4 weeks ago to see me and wanted a crown had come out. A couple of these front teeth are all like gold crowns, like hanging on for dear life, like root caries everywhere. And they were just failing. And, he's gone, well, they've said it's going to be 9 months until I can do anything. So what can I do to fill the spaces? So we're sort of like, well, let's make some acrylic dentures, and go from there. So he came in on the Tuesday, or they called on the Tuesday, and I was seeing him on Thursday anyway, and he was seeing Nick on Thursday for a plan. So we sort of called our lab and said, look, you've got these files. Can you make us a tray in a day and a half, and I'll come and pick it up on Thursday night. So he had the files already, made some special trays, and we had a wax, digital wax up, which we then used almost as a set of rims, really, and a sort of half wax try-on as well. So in the space of a day and a half, we had trays and wax rims, so to speak, ready to go. And then I've done it analog from there. But everything has been pre-planned and set out. The wax up is going to need the teeth in a better place because they plan to move things backwards for implants and whatever. But obviously we're putting flanges in, things like that, so it wouldn't make sense. But it's really useful in that sense to be able to very quickly pull off a record off the cloud or wherever it is and do something there. And I think that's another useful side of it, isn't it? You can do those kind of things very quickly.
So essentially the primary impression was digital. That's essentially the way it was done, right?
Yeah. So he printed some trays. He designed the trays on CAD as well and printed them. And then I've got them. My issue with it, and we'll get to it with dentures, I don't think it was very well extended because soft tissue, scanning, free-end saddles. But to be able to get a set of trays in a day and a half is awesome. Yeah, so I think And definitely for planning and sitting there, and it's just better than a set of photos is great, but if you can sit there and twiddle around, and it's gonna be better, isn't it? And obviously planning ortho wise, I don't do any aligner stuff. You do quite a bit. You've got a dip, haven't you, and things like that. So I'll leave you.
Yeah, I
to
got
talk
diploma in
ortho.
orthodontics. I mean, everyone's seen already. Invisalign's the big player here. I have dabbled with other systems, but I have no financial interest in Invisalign. But what they spend on research and development per year is more than what these smaller companies make. Right, their bottom line in terms of what they do with aligners. They've got the best printing technologies. They've got a really great system. Yes, I've heard things about their customer support not being up to scratch and that kind of stuff, but they're just huge. They're the monopoly, and their product is damn good. And I think with the planning side, with the outcome simulator, patients going crazy for the outcome simulator. Just that alone is so powerful. Even their little QR code that you can scan in the waiting room, and the patients can take a selfie of themselves and fix their teeth digitally. I thought that was so clever when they brought that out. Yeah, 2 years ago they brought that out, and that's a huge AI wonder. I think that patients with dodgy teeth can just take a photo and fix their teeth instantly. That's a huge motivational factor. We talk about emotional dentistry and motivation stuff. I think Invisalign nailed that. So I think, yes, outcome simulator, phenomenal.
Yeah, I don't know if there are any orthodontists watching, but if you have any thoughts on that, let us know. If you still want stone models, I think I've still got my stone models from my twin block appliance from 15 years ago, whatever it was. I don't know really. I think especially is Trios and things like that. Are you able to use Invisalign, or have they literally just set it that you have to use iTero? Because obviously they run it as well, don't they?
Trios 3 in the UK, as far as I know, Trios 3 you can, because I do. Trios 4 you can't. So that's the issue there. Medit you can't. So I'm trialing a Medit soon actually. So I'm using Trios, I'm using iTero, and the guys from Medit reached out to me saying, okay, you've tried the rest, and I try the best kind of thing, So okay, I'll give Medit a go as well, and just give them some feedback. So that'd be pretty cool. But with the orthodontist side, I think before we move on to the next topic, it's worth mentioning that a lot of these orthodontists, even when they're doing fixed brackets, they can plan so much all digitally and get their brackets delivered in a way in the tray. The whole tray and the indirect method of bonding, but it's all been planned digitally. You digitally position the brackets on the model, and then that tells you how much intrusion you're going to get and how much extrusion. So it doesn't kill the art of actually placing brackets, but it makes it more predictable. It's using technology in a good way. Alan's here. He likes the Medit.
Alan's here. So that's a glowing recommendation for the Medit for you. He's got good taste. But
the problem with the Medit is Invisalign. If you're doing Invisalign, then that's a drawback. But if you're in a practice like I am, whereby you have an iTero and I've got a 3 shape, and if I was to get a Medit or something, then for the Invisalign case, you can use the iTero, right? And nowadays, I see more and more practices going in that way. They got more than one scanner, and sometimes people are saying, okay, let's get a couple because we know scanner X is good at this and scanner Y is good at that, and people are mixing it up.
Yeah, it's going to come down to what you're doing more of and what works better or best in your hands. Same as everything, isn't it? What works best in your hands for what you need to do. I think that's something maybe we can get to. Yeah, I mean, I only use iTero, so but you've had a dabble with everything. Crown and bridge stuff, that's the main thing I'm using it for. I really like it. Really like crown and bridge. I still quite like taking an impression, but I'm just sad like that, aren't I? But
you definitely are.
Reduction monitoring and things like that is ace. Just process through. The only problem is mine. I'm downstairs and it gets a bit slow sometimes. And you're waiting, and then you have to adjust a tiny bit, check it again. You're like, but that's so handy. And even just visualizing it for a patient, if you say having to take down a plunger cusp or something, that's the problem that broke it in the first place. Let's just polish that. Again, it's communication. It just aids that so much easier. I mean, what are you for? Obviously, you're doing it all anyway, but bridge stuff, resin bonded. I know you like your RBBs as well.
A to Z, that's right. Yeah, A to Z digital for that kind of stuff is great. But I would say if I was to audit myself, I'd say 10 to 15% of the time when I'm doing a prep, when I go to the final screen to check the occlusion to make sure I've got enough clearance for my material, I would say 10 to 15% of the time, I'm going back and I'm just getting my soft flex disc out or just a quick bzz of the burr, And it's just phenomenal to be able to do that, to give it the optimum thickness for your material. That's just so good. As you mentioned, patient consent, like you said, the plunger cusp, that's great. And nowadays, I mean, one thing I just want to mention as a learning point for everyone is that if you're making the transition, I saw Kish mention that he's got the Trios 3 soon. So the thing a message I want to give to everyone is if you're making that transition from impressions to digital, remember this, that no matter how much retraction you do in the analog world, you have to retract more aggressively in the digital world. So you have to push the Teflon in or the retraction cord in a little bit harder. You have to leave it there a little bit harder. You have to use the bigger cords. You have to use your Viscostat Clear for longer. But when you do that, then amazing. And sometimes I pull out my thermocut burr and just cut some gum away because sometimes you just have to, right?
Mm-hmm. And then, you sort of alluded to earlier, you're doing a lot of dirty prep stuff. And initially digital was struggling with that, but you're feeling that's getting better and better. And do you have a preference then? Are you using the iTero or are you using, the Trios?
So you mentioned a great point earlier that every time you have to get a scan, it's annoying because you have to go downstairs and stuff. So it's the same thing with a camera. I always say camera has to be there, set up with the lens on, with the flash on, ready to go. Then you'll use it. And you obviously, a testament for that. Your photography is far better than mine. It's beautiful. But it's the same with the scanner. If you have the scanner there, I'm sure you'd be using it twice as often, maybe, if it was just there, ready to go, right? Instead of having to carry it. So I think that's a huge factor. And the vertical stuff, I think I was just scared before of not capturing what I wanted to capture. But with the protocols in place, I'm very confident now. So like I said, I hate taking impressions. No offense, man. I just feel like that's so old school, man. I mean, for dentures, which I don't do much of anymore, I would. And I don't know if you probably know people. Is anyone out there you think making dentures fully digitally? I'm sure there is, but
I had a few people when I teed this up, a couple of weeks ago, and they said, "Oh, I do all my stuff digital, and you won't go back." And I get bounded chromes maybe because it's all sort of complete tissue, like hard tissue support.
Mm-hmm.
I just think, are you ever going to get the full extensions and things and soft tissue and that difference in pressure? If you can do a scanner that does that, then that's just mental, isn't it? But
what about the peak stuff?
Peak in terms of
dentures instead of chrome, the peak 3D printed. Does that have a future in that sense?
Right, yeah. I mean, Ivoclar they're doing a really cool thing, which is like a pre-made block of tooth color and acrylic, like a disc, and they literally print it off as one big chunk, and they can make a denture in like minutes, and it looks mad. But that in terms of milling and things like that. But again, it's the same. It's going to be the whole CEREC argument. You're going to get maybe a great fit or whatever, but you're never going to get the same as a master craftsman. Mike says can't be done to scan the models.
But also we had another question. Cox and Hitchcock Dental Group, what's your verdict for Trios or iTero for non-Invisalign cases? What do you reckon, mate?
I just use iTero, so that's going to be one for you.
Okay, fine. So I would actually say that the scan quality just looks better on a Trios. Even though it takes me a little bit longer, I just feel the details I capture, it looks more lifelike. Now, to me, the scanning ability matters a lot, but ultimately, it's even not as important as the printer and the quality of the printer that your lab's using. So that is so important because you can have a great scanner, crap printer, and it's still crap ultimately. So yeah, if I had to pick one, iTero or Trios for my non-Invisalign, I actually go Trios. It just there's no logic other than that on the screen, it looks like crisper to me, right? So
on the
that's the way I see it. It's true.
I mean, to be fair, those are the ones that I see. You see a Trios, oh yeah, that does look good. Mike says peak ones look awful. They're way too bulky. There you go. If Mike thinks it,
I have no experience in it. So there we are. Thank you, Mike.
Nah, I do. I say everything else. So yeah, next thing really is dentures. I think the hybrid case. I said we had some design trays and things. They weren't. I'm looking at them. I'm getting the models in on Friday. I'm doing the case on Saturday for the try-in. Again, awesome that we've got it turned around so quickly. But in a normal procedure, I would have just taken primary impressions rather than doing a scan to make it. So in this situation, it was handy. But then I felt that I had these I thought they were very under extended trays that I then had to put a lot of work in with putty, not compound like, putty really working it. And it just meant that I was essentially doing an even harder primary impression than I would have had to have done. So yeah, for this instance, it was handy because it saved two weeks for this patient. But I think if I'd seen them fresh, I'd have just got a stock tray and done what I normally do. Ask on the BJ soon, take a look. I won't be impressed. So I think, a bounded, again, like if you're doing a bounded chrome, I think it'd be perfectly fine to scan that and get some trays made. A freehand saddle, I just don't like it. A complete denture. Again, I've seen some people doing it and then I message them and they say, oh yeah, but I still take a proper secondary impression.
So it's just for the primary imp, right?
Yeah. So I'm just
it's a scan, yeah. I did that once because I literally couldn't get a stock tray in this woman's mouth. I just couldn't do it. So then I scanned and then I was able to get the traditional special tray made for a full denture. And that was really handy. It was a lifesaver there as well. But one tip, I don't know if you've tried this before, is that if ever you've got like an edentulous region where you're struggling to scan, you put these little dots of flowable around. It allows it to track. Yeah. That's a cool little thing that has helped me once or twice. But like you said, you're going to be eventually going down the impression route anyway, I think.
Yeah, and as I say, normally if you're doing it, if you're bringing them in for a session to do a scan as a primary, I'll just take a proper primary. It's not going to make a difference. Funnily enough, though, for a denture on Monday, I did actually do a scan because I couldn't get a stock tray in her mouth. So it was, she had 6, 7, and they were really wide, and she had really tight lips, narrow lips. I don't know how Nick got anything in there in the first place to do her implants and stuff. But she had a top denture that she didn't like. And I tried to scan it and I just couldn't get anything labially. So I clipped the denture in, scanned it with the denture in, and I've sent it to Ricardo and just said, just cut off all the teeth that are on the denture and make a tray over the top of that. So hopefully that works. We'll find out in a couple of weeks. I'll keep you posted. But
that also is useful, isn't it, for Ricardo to have like the baseline? Like usually you take an alginate of their denture, but if you just print the scan, then or just view it, he has some sort of he knows where the patient's coming from, right?
Yeah. So yes, and exactly. So he's going to start off when I did a lower and I did it in occlusion and everything. So he's got her lower, her full mouth already. He can pre-articulate that whatever he wants, and she wants to push everything out a bit more and show a bit more too. So it'll be quite a nice starting point. Oh, the effects are on. It'll be quite a good starting point for him to line it up with the photos that I've taken and sent, full face and all that. So yeah, so it's handy in that sense as well. Would he want normally more than just photos? Would he want a scan normally? I don't know, I might ask him, see how this case goes, I guess. But yeah, I think if you're just going to take a scan to then take a secondary, just take a primary anyway. That's for me, I think. Because you're never going to get, especially if you got a flabby ridge or something like that, you're never going to get an accurate, properly supported, properly done thing. Now, this is the big one. The last sort of thing I've got on here. Your area of expertise, splints. Where are you at?
So I am looking at different options of 3D printers that are not extortionate and can print some chairside splints, like a quick B splint. A lot of people are doing that now in the US, and so it'd be great to be able to offer that instead of having to wait, 2 weeks to turn around, because they're not difficult to make. But flat plane appliances, anything that is, or what a lot of practices do actually is they print the model and then they make an Essex or even make a B-splint at the practice. A lot of American practices are doing that. So I think, yeah, if you're making splints and stuff, it's so easy to incorporate that. But I just think you need a good printer in your practice. Now, Formlabs is out there and they are compatible. I'm looking at a few others. A few companies have reached out to me because I've been sort of looking. So watch this space. Very exciting in terms of doing more chairside, 3D or milled splints, if you like, or printed. I don't know what the correct term would be in that sense, actually. And that is something that's going to make it more accessible and easier for patients. And maybe even, it's going to save you money because you're not having to send it to the lab anymore. So, but not all scenarios obviously are possible.
Yeah. What are your thoughts on taking, like eccentric bite record? I saw George did a really good tip the other day saying actually take an occlusal front little record, and then you can just click that in, and then you can scan them. And I was like, I literally had never thought of that, and it's so simple because you're still just scanning at the back, aren't you? A relationship.
So I can show you something because I knew this would go in that direction. So, so this is a lady I was making a dual arch B-spline for. She's got chronic pain, right? She had chronic pain. You can see, oh, I actually forgot this is not touchscreen, it's my laptop. Okay, so this lady, right? So we made her an appliance, and the problem is, like, if you zoom in here, like, that's almost touching, right? That is literally almost touching. I know it looks like it's the wrong plane, but they're almost touching. So what I did was I stabilized it anteriorly with a leaf gauge, okay? And what I found is it came up to around about 32 leaf gauges, and at that point was our first point of contact. So just let that sink in. At 32 leaves, like that much gap pretty much, she was still touching her sevens, right? But her MIP is, all the teeth were touching. So she has a huge slide vertically and horizontally, right? So if I didn't take the scan in this position, if I just took an MIP scan, I told my lab to make a splint, like an anterior only appliance, then at night time, when she went into a centric relation, i.e. by maximum clench, she would have bashed into those molars, right? By actually diagnosing the fact that she has a first point of contact at this many leaves, I then just added a few more leaves in there, and I scanned this, and I sent it to my technician. I said, when you make my splint, make sure you give me this OVD or more, nothing less. So that is just so handy to be able to just keep a leaf gauge at the front and just scan the left and right bite, and it gives you this. And a lot of my dial cases I plan this way. And the real trick here is if you plan it at your desired vertical dimension. You put the leaf gauge in, you say, okay, this is how much I want the vertical dimension. You put the leaf gauge in, scan them, and then you tell the technician, don't touch the OVD, just fill in the blanks. Digitally, just put wax everywhere and make everything meet anteriorly. And my God, when I've done this, and you do the injection molding or pressure molding or whatever, and you get the patient to bite together, just beautiful centric contacts, minimal adjustment needed, because it's just, they're not having to raise the OVD. You don't get those arc errors. Everything's there at your desired OVD. So that's a massive hack when you go into digital. It's the beauty of it.
It's visualizing it as well and checking it, and you can go back and alter it. And you're going to have to come and play with the module, because then you can you guys,
when COVID's gone, you guys got to have like an open evening where you just come and play with the module, man. That'd be really cool.
Yeah, it's so for people that don't know, the module essentially is a way of setting up digitally the patient's jaw relation, essentially. So you import your scan. I think you can definitely do it with our iTero. I'm sure you can do it with Trios as well. You download the file into the module, and then you use a little clip on the front teeth, a little tiara. It's a strong look. And then you do a few points in the mouth with a little wand thing, and it works out the distances. And then whenever the patient's moving, you've got that. And then you can record all of these movements. Whether it's, you can do a Gothic arch tracing, because Alan loves that. You can just do excursions, and it shows you this heat map, and it's so handy to see like non-working side contacts. You can see all these points where things are, and it's good, and it's probably going to line up with wear facets and all that kind of stuff. Formlabs have a great 3D printer. There you go. And Harry says that's a great tip. He's still scanning and sending Facebook.
Yes, Mahan. Mahan's not even a dentist. He's just my old one of my best friends, man. Mahan's just a really cool guy who knows a lot of shit about everything, but he's not a dentist. He's a really cool guy. Nice way to show her AOB risk. Absolutely, Alan. You know it.
What's this hashtag the splint course? Are you doing a splint course, Jaz?
It's been and gone, my friend. It's been really well received and stuff. So I had my first person. Thanks, man. I had my first person finish the course. So it's been out a week, and the first person has finished all 10 hours. Can you believe 10 hours of spin content I made? I've got one more hour coming up as a bonus module, but he's finished 10 hours, and the feedback was glowing. Shout out to Nasir Javed if you're watching this right now. Mahan, absolutely, you're totally right. Harry, I just want to pick on what Harry says. He said he liked that tip about he's scanning and sending face both. So I used to do that, Harry. But when you start doing it at the desired OVD with the leaf gauge, that's one thing. But then what's the risk? The risk is still the cants. You can still get cants because one of the things that face bows give you is that information. So here's how I get around that. You take a really good full face photo. Okay, make sure they're looking at horizon, all that kind of stuff, and then you want to also take a photo of them with the retractors in, okay, but still a full face, okay. Then you see the relation of the eyes and relationship with the teeth, and then you send them the actual zoomed in 3:1 photo, and basically you tell the lab, okay, there is a cant already, and then you tell them lengthen upper right 1 by 1 millimeter, lengthen upper left 2 by 0.5 millimeter, lengthen upper left 2 by this. So you guide them. So you can then correct cants or prevent cants by being very prescriptive, and of course a microbrush. But then with the microbrush, again, you're introducing something analog into the digital again, right? But yeah, a microbrush, a nice little stick bite, bit of a blue mousse, something. Get them to bite on the microbrush, and then you make that either a pupillary, or if they've got bent eyes, look at the behind them. If you have some something horizontal like blinds, and you take a photo of that as well. So the pen or the microbrush should be parallel with the blinds, which are true horizontal behind you. So those are the most common things that we can sort of slip up on when it comes to digital.
Yeah, and that's exactly what. That's the one thing we haven't talked about. Photography. I'm assuming you're not using film for your photography. It isn't digital.
Yeah. Yes, of course.
Perfect, man.
I'm just replying to Michael. He's mentioned about the Bellis. I have no experience with it, but I know it's what Ian Buckle uses. If anyone has used Bellis, tell us, because it looks great. The whole Bellis 3D face cam. Hopefully I can start dabbling in that in after April, when good old Rishi has introduced the 130% rebate kind of thing. So these cool toys, I think dentists going to go crazy buying loops, camera equipment, scanners, Bellis. I think a very exciting period. Yeah, modules. Oh my goodness. Yeah, I think this is a very exciting period for investment and development for dentists.
I think you've got your eyes on your toys, haven't you? They're going to send you your new scanners, and so you're thinking of doing all your printing in house then? Or printing?
No, not all the printing, but it'd be cool to have something to be able to some element of it to be able to print some things. Maybe it's just study models or splints for sure. I want to be able to do splints. That'd be really cool. That's the next sort of that's the next goal for me, I think.
It beats a Blobolux attempt on an impression tray handle, doesn't it?
You did brilliantly. You did fantastically with that, and look what a massive difference you made to that patient. Really cool.
No, that's cool, man. If anyone has any questions, by the way, or any other things they want to discuss, just drop it in the comments. Can you think of any other uses? Have we missed anything? Implant stuff. I mean, Nick loves all his. He does all of his basically start to finish digital. So he's doing, obviously CBCT, lining it up with iTero, making digitally produced splints for guided surgery, scanning everything. I don't know if there's any implant guys on. Alan, if you're still here, what do you do for implants, bud? But yeah, I think Nick loves it. Nick goes at pretty much everything digital apart from dentures. Are you dabbling in implant stuff?
No, I'm not dabbling at all. I know my principal in Richmond wants me to start dabbling a bit more so I can help him with the restorative side of things. And my viewpoint has always been, I love general dentistry, but I think you have to draw the line in the sand, because I'm the kind of sort of personality that if I'm going to go into a field, I mean, that's why I did a diploma in orthodontics, because I really want to know what I'm doing, right? If I'm going to go into implants, even if it's just restoring, I want to be able to go on some courses and stuff, and to really get the time, the money, the energy to do all that. But I still do the whole crowns. I still do the odd endo. I still do lots of crown bridge work. So it's difficult being the master of sort of jack of all trades, right?
Yeah.
But I think the future is, I need to be able to restore implants for the future. So I think, leaving something for the future is something's good as well, something to look forward to. Right, so I think that's my next 5 years for implants. Exactly.
Alan,
hard things I should dabble.
Scans in a CBCT. Yeah, I think it's good visualizing. If you're doing guided and splints, splinted and stuff, it can make your life a lot easier, more predictable. But like I was saying with orthodontics, maybe does it take the wizardry out of it? I think it's just sensible, isn't it? It's just reliability and planning, and because why would you not want to make your life easier? I think it's pretty
100%.
simple, isn't it?
Rajab just asked, have you tried digital articulators? I haven't yet. It's not the labs I work with. They haven't really said they've got the technology, so I'm still taking lots of photos, the scans at the desired OVD and stuff. And for me, I'm always testing in temporaries. And once I've got it right in temporaries, I scan and I get the lab to copy. That's the approach I followed. I don't know how accurate these digital articulators are. Can they give us more information compared to the really good photographs and the scan that you give at the desired OVD? Probably. I think that's going to be cool. But I think that's where the module comes in, right? I mean, digital articulation, can it really get better than the module? I don't know. I don't think so.
I think I haven't done any cases myself with it. We're going to do a live at some point when Nick's going to do it on me, so we can
That'd be cool,
show
man.
everyone what's going on. He's done a few cases with it. I think it's just about working out how to use it. I mean, I'd love to be able to use it for like denture stuff, for like complete dentures, but it's just working out when in the workflow can you use it, because you need to have everything set. Because you need these points of reference. So it's not, you need to have some sort of sturdy base plate to be able to, so essentially you're just doing Gothic arch tracing anyway. So after Alan taught us all so well about Gothic arch tracing in our one before last, then why would you not? Mike's asking a little photography question. There we go, digital photography. What DSLR are you guys using? Are you mirrorless? I'm mirrorless. I'm using a Sony A7R3. Purely because I like photography anyway, and I got that. I do landscape photography and stuff, and I've had to make it work for dents. I wouldn't recommend it because I've had to make it work with other stuff. But for what I do of mostly taking portraits of patients for denture stuff, I've just got two big flashes on stands. My owl bracket setup is bulky as, but mirrorless is great. I think the photos look slightly different to the Canon and the Nikons, but I think it's purely just color science and how I just tweak with contrast and stuff. But I don't think there's any benefit. There's no benefit for dental. It's not that much lighter because mine's a full frame one. If you had one of the crop censored mirrorless ones from Sony, they're like teeny tiny. But I don't know what the macro lenses are like for those. So my setup's not that good or that light.
I would say, well, I'm using a 60D Canon old one, right? And you can see the photos are fine for dental use. It's all good. But I had someone on the podcast recently, yet to be released, maybe next week. We did a group function because one of the questions I get is, Jaz, which camera should I buy? Like, can you just do an episode of which camera? Just because people don't want to do the research. People don't want to have to go on those comparison websites and dentists are giving like conflicting advice. Oh, get an 85mm lens, get 100, get 105. Get this for the Chinese brand Yongnuo, get this for Nissin. It's very confusing when you're buying a camera. So I asked the guy, okay, you're a new dentist, which camera should you get? He recommended a mirrorless one. He recommended a Nikon mirrorless camera because of the focus peaking. So that you don't have to now, because now with loupes and the hood and stuff, you don't have to look at the viewfinder anymore. You could just look at the screen and then all the bits that are in focus, like in the canines, for example, you don't get the canines focus, they will just go yellow or whatever.
Yeah.
And that is going to make it so easier for your nurses, for dentists to take photos more consistently and easier, and they're lighter as well. So it made a lot of sense. I think the future is mirrorless, my friend.
Yeah, I think it depends. I haven't looked into the Nikon or the Canon. I would say if you're looking into cameras and buying cameras and investing, just from the photography world point of view, be wary of Nikon because they're not doing that well as an overall company. Their market
I didn't know that. Wow, I didn't know that.
If you're going to go into if you're doing Canon v Nikon, I'd say go Canon just to be safe. They're not going to explode tomorrow, but their R&D is disappearing. They're not doing any development of new stuff really. But yeah, there are benefits to the mirrorless. Like on mine, they all have it now. I've got eye autofocus as a preference. So I've got a little button on my lens. So when I'm doing a portrait, I click that, and instead of having, square point, whatever, it focuses straight on the pupil. So the portraits come out like unbelievable.
That's brilliant.
They're like pin sharp every time. It's just so easy. Just click on the lens, bang, done. And then that makes it really good. But then there's issues with, and I think someone put it on Minish's focus group about, I think they've got a Canon R5, which is their main mirrorless one. And if you have a manual flash, you can't see anything when you're taking the photo, because the viewfinder is a digital screen. It's an electronic viewfinder. So the camera is seeing it's showing you what it thinks it's going to see.
Mm-hmm.
And because it's a manual flash, the camera doesn't know it's there.
Mm-hmm,
So it
mm-hmm,
thinks,
mm-hmm.
oh my God, you're on f/22 and 1/60th and I can't see anything. So like on mine, if I've got my ring flash, because Sony don't have one, so I've just got like a Godox manual one. When I focus, it briefly flashes and then goes away again. So I have to like guesstimate what's going on. So you need to have a TTL ring flash or a TTL flash system with mirrorless, so that the camera knows, right, I'm going to put this much flash into it. That's the only thing. And I think Canon's better for that than the Sony. But Sony's getting there slowly, so I'm going to persevere.
Good man.
Yeah,
that was a great question. That's a great question, Mike. Sweet. I think we've covered no more questions. So
yeah, if anyone's got any last ones, get it in. But yeah, no, man, that's awesome. So you've already said April ortho. What else can we look forward to on the podcast and things? If you guys haven't all subscribed, go and subscribe, because it's awesome, and listen to Splint Timber because it's ace.
Appreciate that. Thanks so much. So yes, April is straight pro, so lots of ortho content to help GDPs with ortho. We even had the debate of how far should GDPs go? Comprehensive versus compromising. When is it okay to compromise? When is it not? We're doing that kind of stuff. In May, I've got your episode along with a really cool one called Productivity with a Prosthodontist. So I've got my good buddy Ricky Bhopal on, and we talk about productivity hacks. Like, he's really interested in being as productive as possible. So we've got that kind of stuff. And I mean, the content calendar is full for the next 3 months. It's just, I sort of choose, okay, what's everyone feeling right now? But it's so time intensive, man. Being a wet-fingered full-time dentist, a dad, the podcast, the course, it is quite full on at the moment. So I would like to be able to put more content out, but it is the way it is. We're all busy practitioners, and that's the beauty of it, right? You have to juggle it in the real world. Everything you say has more gravitas and authenticity when you're when you're feeling the daily stresses. And speaking of stress, the next episode coming tomorrow is managing stress in dentistry. There we are.
There we go. That sounds like crack. I mean, let's leave it on this last question. I'm going to leave it to you because I feel embarrassed that I'm even in the same league. How do we get beards like you guys? I'll leave that up to you, mate, because
that's a great hat there. So Mike's really covered it.
Don't show it.
You know what? My beard is actually, just so everyone knows, my beard is actually like there, like below my waist. They've seen it's like really long. So I use the Schwarzkopf hairspray to sort of bundle it all together. And that's all the wonders of hairspray, actually. So, yeah, hairspray goes a long way. Let's see, Mahan was saying, Nikon R1C1, you don't need ring flash. Canon the way forward. Mahan, man, I was going to buy a Nikon as well. I have to buy a Canon now. Thank you.
Yeah, I'd go Sony. They're awesome.
I've got a Sony here, actually. I actually use my Sony for my podcasting, so there we are.
Oh, is it was it the VR1X, is it, or?
It is, I think, the ZV1. It's more like a vlogging, YouTubers kind of one, yeah.
Do you find that's wide enough? Sorry, we're going really off topic now. It's not quite wide enough for vlogging.
Oh, right. I mean, I don't know.
Handheld.
I think so. I think with myself, I've got this like really fancy tripod and stuff. So the stuff I want to do, it works wonders. And with patient stuff as well, I often do some filming with patients for my Splint course and stuff. So it's done well. So
perfect. Cheers, buddy. It's been awesome. And
thank you, Rupert. I'll catch you soon. Look forward to your episode, my friend.
May, yeah.
May. It'll be awesome. Take care, buddy.
Cheers,
Thanks so much. Nice one. Bye.